Total thyroidectomy versus lobectomy for sporadic medullary thyroid cancer. Welcome back to the Head and Neck Oncology Journal Club. I am your host and this is episode 12. This week we are looking at a study just published online in JAMA Otolaryngology Head and Neck Surgery by Lin Sango and colleagues out of Mayo Clinic and multiple international centers. The title, Total Thyroidectomy versus Lobectomy for sporadic medullary thyroid cancer, a systematic review and meta-analysis. So here's a clinical question. Total thyroidectomy has been the standard surgical recommendation for medullary thyroid cancer, both hereditary and sporadic. That recommendation makes obvious sense for hereditary cases where germline RET alterations drive a multicentric disease process. But for sporadic MTC, which accounts for about 80% of all MTC cases, confined to a single lobe and without germline RET alterations, the rate of bilateral disease is low. We are talking 0 to 9%. Meanwhile, total thyroidectomy carries real problems. Permanent hypoparathyroidism, recurrent laryngeal nerve injury, lifelong thyroid hormone replacement. So the question is, for carefully selected sporadic MTC patients, can lobectomy provide comparable oncological control? This is a systematic review, searched Medline, Embase, Scopus and Cochrane Central Register through December 2025. 9 retrospective studies met the inclusion criteria, comprising 1,371 patients, 531 in the lobectomy group and 840 in the total thyroidectomy group. Primary outcomes were mortality, overall survival, structural recurrence, biochemical cure, and distant metastasis development. They used random effects models with Knapp-Herteng adjustment. Risk of bias was assessed using Newcastle-Ottawa scale. It was high in 4 studies, moderate in 4 and low in just 1. The patient population was generally favorable. About 71% of the tumors were under 2 centimeters. Roughly 57% were node negative. Over 82% lacked extrathyroidal extension. Multifocal disease was uncommon at 9%. And 90% of the lobectomy patients underwent central neck dissection. Now for the results, and this is getting very interesting. Regarding mortality, no difference at 5 years. Risk ratio 0.30 with a confidence interval of 0.07 to 1.35. Beyond 5 years, also no difference. Risk ratio 1. Overall survival at 5 years, no difference. Risk ratio of 1.02, confidence interval 0.94 to 1.11. Biochemical cure, no difference at 5 years, odds ratio of 0.86, no difference beyond 5 years, odds ratio of 0.87. Distant metastasis development at 5 years, no difference, odds ratio 1.64, though the confidence interval was enormous, 0.09 to 31.52, reflecting very few events. The one finding that did reach statistical significance was structural recurrence beyond 5 years. Odds ratio 7.26 favoring total thyroidectomy with a confidence interval of 1.07 to 49.21. But here's what's critical about that number. First, the heterogeneity was high at I-squared 77.5%. Second, the confidence interval is remarkably wide. And third, the most important, this finding was driven predominantly by a single small study by Ma et al. From 2011 that reported an odds ratio of 16.33. The largest and the most contemporary study, She et al. From 2025 with a propensity matched groups actually showed no difference with an odds ratio of 0.83. And when sensitivity analysis excluded studies that defined sporadicity purely on clinical criteria without germline RET testing, the structural recurrence difference disappeared entirely. One more important point, post-operative complications were more common in total thyroidectomy group, which is exactly what you would expect. There are important caveats. All 9 studies were retrospective. Patients selected for lobectomy almost certainly had more favorable tumor biology. Germline RET testing was only available in 6 studies, and the definition of sporadic disease varied. Preoperative calcitonin reporting was inconsistent. Long-term follow-up beyond 5 years was limited, and overall certainty of evidence was rated as low. The authors appropriately emphasized that non-significant findings should not be interpreted as demonstrating equivalence. Here's the bottom line. This is the first systematic review and meta-analysis directly comparing total thyroidectomy and lobectomy for sporadic medullary thyroid cancer. Across mortality, overall survival, biochemical cure, and distant metastasis, no significant differences were found. The one finding favoring total thyroidectomy, structural recurrence beyond 5 years, did not hold up in the sensitivity analysis. For carefully selected patients, we are talking unilateral tumors, germline RET negative, under 2 centimeters, node negative, no extrathyroidal extension, lobectomy with central neck dissection appears to be a reasonable option. This aligns with NCCN, Japanese, and emerging German guideline positions. But the evidence is retrospective, certainty is low, and confidence intervals are wide. This is not a mandate to change practice. It's data to support shared decision making with patients who meet these criteria. That is episode 12. I'll see you in the next week. Thank you.